Hello everyone, today I'll be showing you a surgery wherein we have implanted a spherical ICL. So the first thing I like to do is load this lens. So here we are in the cartridge using a combination of a dispersive viscoelastic along with BSS, and then we are removing the lens from the bottle with the help of a special sponge tip applicator which comes with the ICL, as the ICL is very delicate, and this is what is recommended to handle the ICL instead of using like McPherson's forceps or IOL holding forceps. Then we have the special pull through forceps to get the lens a little bit in front of the cartridge so that we can load it in the eye. So the trick here is to pull this cartridge back with the other hand instead of really pulling the lens. Once this is done, we put the sponge tip applicator inside this injector and then we lock it and place the lens in place, and then we just move it forward to make sure that it's moving. Now we come to the patient, and through a side port we are injecting again a dispersive viscoelastic. Avoid overfilling the chamber, just enough so that you can see the chains of the viscoelastic, and then we are creating the main incision here. To comfortably load implant the ICL inside the eye, we need about 3 or 3.2 millimeters of incision. And next comes the step of implanting the ICL. So here it is important to implant the lens slowly, carefully, looking at how it's opening up inside the eye. So what we are looking for is that hole in the haptic should be at the right leading haptic. So the hole should be at the right leading edge, and that means that the vault is correct and that the ICL has opened up in the correct position. If the ICL is flipped, then we need to remove this lens and reload it. Now we are using this special iris tucker instrument to tuck all the haptics under the iris, and we see here, although this was not my intention to directly place the haptics under the iris, but while injecting, the two leading haptics have already gone under the iris. So the remaining are being pushed under the iris very gently and effectively with this instrument. Now we are removing all this viscoelastic using a Simcoe's cannula here. I prefer to use Simcoe's cannula because it puts lesser pressure on the eye, although an irrigation aspiration can also be used, that we typically use for FICO emulsification. And in the end, I like to inject a little bit of pilocarpine just to make sure that the haptics remain in place. And that's the end of the surgery. Thank you for watching.